problems of this disease is that it's very different than many cancers, because if you have a well-differentiated tumor, it's usually slow growing. And slow growing, then it can sometimes be a disease that has its course over decades, plural, as opposed to weeks or months or a year. So when you think about treating this cancer, it's really different than how we treat a lot of other cancers, where we throw all sorts of therapy at a patient all in 1 year or 6-month period. In this disease, it's often doled out over a very long period of time. So it's different than the approach to a lot of other cancers. As I mentioned, there are a lot of team members involved, and many of you over the course of your disease illness will have interface with a surgeon or a interventional radiologist, nuclear medicine specialist, etc. So you have this team of providers. The optimal sequence, as I mentioned, is not clear, and so you may find that sitting in a room like this, the path that you've gone down and the order in which you've done things is really different than the person sitting next to you. And we'll talk a little bit about what factors influence the choice of therapy in the sequence. But there's really no one-size-fits-all approach. There are guidelines, but ultimately it comes down to what's right for the individual person. I also wanted to mention that interpretation of imaging and pathology is not straightforward. And I would say for the amount of experience we have here, which is quite extensive, we have very long discussions about pathology and about imaging, because there are a lot of details that are not necessarily clear from the reports. And also, a lot of the interpretation can vary by the person looking at it. And it's hard to stress how important pathology is. I have a slide up here showing pathology, but what I've learned from my peers is even the most expert pathologists can have a difficult time classifying neuroendocrine tumors in some situations. Sometimes it's really straightforward, other times it's not. And I would say that's something that I just have found really educational learning from our pathologists, is that it isn't straightforward when you look at it under the microscope. Sometimes there are additional tests they can do on the tissue, either molecular tests or tests with antibodies, which is called immunohistochemistry, that can help sort it out. But they essentially are trying to, when they meet a patient or learn about a case, they're trying to decide if it's a well-differentiated tumor, which is the slow-growing kind, versus a poorly differentiated neuroendocrine carcinoma, which is a much faster-growing tumor and has a different treatment approach entirely. But I want to point out that the classification system changes over time, and you may not be aware of this, but one major change was in 2010. That was when the Ki-67 became more widely incorporated, which looks at proliferation. And then another big change was in 2017, which was when this new category was identified called well-differentiated grade 3, which is sort of an intermediate category between the poorly differentiated neuroendocrine carcinomas and the low-grade G1, G2 tumors. But the point I want to make is what I can tell you as somebody who looks at a lot of pathology reports is not all pathologists use the same classification terminology or system regularly. And so that's why it's so important when we meet patients to stop, and we almost always redo their pathology and re-look at it and make sure we all understand what type of tumor the patient has based on the current classification. And then I will just mention that it gets even more complicated when you get into the higher, more aggressive grade tumors, because there's even a category that's an emerging called ambiguous, where it's simply difficult for the pathologist to classify whether the tumor is low or high grade. So this is a very important nuance of pathology, and we're often linking the pathology findings with how the patient's doing, because oftentimes you get a sense as to whether it's a low or a high grade tumor simply by the symptoms a patient has or how ill they are. Somebody who's asymptomatic or doing really well, they're working full time, very likely has a low grade tumor, whereas somebody who's gotten sick really quickly over a few weeks very likely has a more high grade tumor. And then one other little nuance I want to mention is that particularly in pancreatic neuroendocrine tumors, the grade can change over time. That's much less common in the other neuroendocrine tumors like of the small bowel. But in the pancreas neuroendocrine tumors, we actually have a low threshold for doing a repeat biopsy at some point. because if the tumor is starting to speed up and it's growing faster than it used to be growing, we'll often do a biopsy to see if the grade has changed, because the treatment may change accordingly. I also want to point about imaging, and Tom and Nick, this is their field especially, but this is just a slide from a colleague of ours who just points out that depending on when you acquire the images after you inject the dye into your arm, you can see more or less in the liver metastases. And this is shown, this is the same patient, the same day, with images acquired at different time points relative to the contrast that's been injected. Now, if you don't have any contrast at all injected, which is often the way a lot of people do their DOTA scans, it's very hard to even see and measure the liver spots without contrast. So we spend a lot of time in our tumor boards trying to compare scans from April to August that were done on different scanners with different techniques, because you can see the variability that's introduced just depending on the images that are acquired and when. Do you guys have anything else you want to add at this point to that? Sure. Okay. All right, so, and I'm going to show you one other example. So this is an example. It's a little bit hard to see in here maybe with the lighting, but this is a patient that has a small spot in the liver, but I just wanted to point out there's 4 different time points represented in this patient's set of CT scans. And really you can see this spot best, in this particular case, on the late venous phase CT. But the same patient had an MRI a couple months before or after this that actually shows the spot even way better. So, and this is a classic problem that we're all faced in the clinic, is you get different types of scans. One month it's a CT, another month it's an MRI. And these often look different depending on the type of scan that a patient has. So when we get a report, we see somebody in clinic and the report says patient with progressive disease. One of the first things that we look at, thank you. One of the first things we look at is when did they do the comparison, because oftentimes they don't have the most recent comparison scan. Maybe they're comparing it to something 2 years ago. What type of scan was it? Did it have contrast? And this is often something we'll be reviewing in the tumor conference, is to be clear, does this person really have progression? Or is this just because the radiologist didn't have all the information that he or she needed to really know whether the last scan compared to this one really shows growth? Or is it due to technical differences? One was an MRI, one was a CT. So big progression, when something grows a few centimeters, that's usually not a question. We get that. But the subtle progression is something we deal with every day in clinic, because it's not always real progression or clinically relevant progression. Okay, and then we're going to come back to the scan, the DOTA scan. But I want to point out that when you read a report that says somebody has a positive DOTA scan, it doesn't always mean that PRT is the right step. And we spend a lot of time going over DOTA scans, and we're going to come back to this as our last slide, I think, today to talk about this, because DOTA scans can be positive in just a couple of tiny areas in a patient, or you can have very widespread disease that's DOTA positive, and the right therapy for that patient very much depends on how much disease they have, where it is, their prior therapy, whether it's in or outside the liver. And again, a big part of what we're discussing at our conferences. So last couple of slides for intro, I wanted to just mention that the main reason, as I said, for these tumor conferences is to try to figure out the right order of therapy for a given patient. And remember, if you have advanced disease and it's slow growing, we often will consider removing the original tumor if we're thinking that it might be causing problems, like a bowel obstruction as an example. And we often sometimes consider removing the liver tumors when it's feasible to do so, with the caveat that it doesn't cure patients typically when you do liver surgery, but instead what it does is we think it sets the clock back, and it can be a really effective way of controlling the disease for a period of time. So this is one of the first things we consider when we see a patient is there a role for surgery, either for the primary tumor or for the liver spots? But then there's a variety of other agents that have been introduced that are more total body treatments. And then there's also liver-directed therapy like embolization, which is what Dr. Fiddleman does. So these, on this slide, I'm really illustrating the treatments that can be done that are if you're not going to do surgery to control the disease. And again, the optimal sequence of these treatments is unknown right now, and so there's a lot of thought that goes into it. One of the main things we think about is, are we trying to get shrinkage, or are we comfortable with stability? And a good example of that would be the use of octreotide or lanreotide. Those are drugs that control hormone symptoms, and they're associated with stable disease on the scan. They don't shrink the tumors. So you have to think about, in a given patient, is that a reasonable goal in that patient? Would we all be happy just with stability? And if so, then octreotide and lanreotide are good choices. It turns out that everolimus and sunitinib, which are pills, are also drugs that cause stability. If, on the other hand, though, you really feel like you need shrinkage, maybe the tumor has pain, or they've got symptoms, or they have more rapidly growing disease, and you're trying to get shrinkage, then that would be a situation where you might use chemotherapy, like capecitabine and temozolomide in pancreatic neuroendocrine tumors. Or you might want to consider liver-directed therapy, where there's a 50% chance of shrinkage. Of course, that's only good if your main problem is in the liver, not if you have lymph nodes or bone disease. And then PRT does have a chance of shrinkage, but it's pretty low. It's about 15% for small bowel neuroendocrine tumors. It might be a little bit higher for pancreas, but the jury's still out on that right now. But that's another modality that we're now using regularly. And then I want to finish by just saying that we talked about kind of the caveats of imaging and pathology and why it's important to be able to be certain you know what disease a person has, where their tumor is, whether it's growing. We talked about the types, the general categories of treatments that we consider. But I also want to point out that every person is unique. And I like this slide because it sort of really integrates what we think about when we see patients. You're looking at what are the characteristics of the tumor. How big is it? How fast is it growing? Where is it? Is it DOTA positive on the DOTA scan? Is the primary tumor in place or not? Is it causing problems? We also think about what's going on in the patient. And I would say a really good example of this is, what is the patient's kidney function? Most clinical trials that are done with patients with near normal liver and kidney function. But the fact is that's not daily life in patient care. I mean, a lot of our patients have kidney problems, or they have liver problems, and you have to factor that into your choice of therapy, because a lot of our therapies depend on what the kidney and liver function is for clearing the drug or for safety purposes, depending on the treatment. What other medical problems does a person have? If a patient has really uncontrolled high blood pressure at baseline, they're not a good candidate for a drug called sunitinib, which is approved in pancreatic neuroendocrine tumors. If a patient has really uncontrolled diabetes at baseline, they're probably not a good candidate for a drug called everolimus, also known as Afinitor, which causes diabetes. If a patient has hormone-producing tumor, insulin, VIP, 5-HIAA, we might be more aggressive if they have symptoms. You know, if they have bad carcinoid syndrome, then even if their tumor's not growing, we might be more willing to be more aggressive with our therapy just to try to reduce the hormones. And then there's the provider factors. So provider or institution, is where you're getting your care even able to do liver-directed therapy, or do they have PRT available? What's available at that institution, and what's the comfort level of the doctors that are providing those that care in terms of delivering that type of therapy? So all of those factors go into what a patient gets at baseline and then at follow-up when their disease progresses, in the order in which they get their treatments. Okay, so multidisciplinary tumor board, this is actually the definition from the National Cancer Institute, a treatment planning approach in which a number of doctors who are experts in different specialties review and discuss the medical condition and treatment options of a patient. In cancer treatment, a tumor board review may include that of a medical oncologist who provides cancer treatment drugs, a surgical oncologist who provides cancer treatment with surgery, and a radiation oncologist who provides treatment with radiation, also called a multidisciplinary opinion. Now, there are different models. Some people have a general tumor board where they might have all different types of tumors presented in the same 1 hour period. The other end of the spectrum is the kind that we have here. We have a neuroendocrine tumor board. So that's all we talk about in that 1 hour, are just neuroendocrine cases. I would say many hospitals are moving towards virtual meetings where people call in or video in as a way of getting all the doctors sort of in one place, and we do a combination here of that, of in-person versus virtual meetings. There are some places that have patients present at tumor board. I would say most commonly it's just physicians that are in the room. And there's a variety of sort of plans for tumor board. Some people present every case that walks through the door, every patient they see. Other places do it more selectively. So if your case hasn't been presented at a tumor board, that's not all that unusual, and I'll explain why in a second. And then the timing, of course, can vary depending on the center. I think there are other centers, like for example at Kaiser, I believe they have a tumor board that probably takes Kaiser docs from multiple Kaiser sites, and they all present their cases at their tumor board. So at our center, I've listed the disciplines that are usually there. Nuclear medicine, pathology is present at some of our boards, medical oncology, radiation oncology, interventional radiology. Our surgeons often weigh in virtually more than in person. We have a genetic counselor there, a radiologist, or nurse navigators, and then we have a lot of trainees that are training in various specialties there. Our particular tumor board meets every other week, and I should point out, this is in addition to many other tumor boards on campus at UCSF. I mean, I don't know the total number, but within GI alone, I think we have, what do you guys think?
3
or 4. We have hepatobiliary, pancreas, general GI, and neuroendocrine.
Oh, and there's 2 livers.
2 livers, and then there's also an adrenal as well. That's separate. So we have a lot of different tumor boards, even within our area that we take care of. Ours is, as I said, mostly in person, but we do have doctors who call in. We have just healthcare professionals present. We usually present between 10 and 15 cases. So about 250 cases a year get presented in this forum, just in our neuroendocrine tumor board. And it's a combination of unusual or really complex cases, cases with a particular imaging question or a particular pathology question where we need somebody to weigh in on those cases. And then most commonly, it's what's the next step of therapy should we do in this patient. And it's often, I would say, relatively common that a single patient will have hers or her case presented a couple of times over the course of their disease. Maybe once when they're diagnosed, another time 5 years later, another time 2 years later after that. So it just depends on when is there a need to make a decision about this patient, or is there a question. And we have doctors who call in from other campuses at UCSF, like the VA and the county hospital, and many disciplines within the UC system. Anybody who sees a neuroendocrine tumor patient is available to present their cases in our group. We then usually try to have a note put in the chart. I find this very useful, but it's a way of us just remembering what was discussed and what the group decided and recommended. And then importantly, one of the things that Tom and Nick often weigh in on is what's the best way to image this patient? Because I'm sure many of you in the room have had CT scans and MRIs and DOTAs, and oftentimes we end the discussion of a particular case as how should we follow this person? Do they need to have a DOTA because they only have bone disease, or is an MRI best because there's liver disease? And those other questions we try to answer and document so we don't have continued questions about that down the road. Okay, so I'm just going to end with the last slide, and then we can take questions for the last half hour, but I'll just remind all of you that the reason why we have these conferences, and I'm sorry this is cut off, the formatting, I must have it on a weird format, but we have a variety of different options to choose for carcinoid tumors, as well as a few more for pancreatic neuroendocrine tumors. The optimal sequence is uncertain, and so really the goal of this meeting is to be clear on what disease a person has and what's the next ideal step. So with that, I'm just going to finish with a series of DOTAs, and I will turn it over to my colleagues to weigh in on some of these issues, and to the group if you guys have particular questions.
Okay, do you want to start with questions or sort of?
Sure, why don't we see if anybody has
Take a couple questions.
particular questions about what we just talked about. Yeah.
How do the patients get access to the tumor board review data?
Yeah, it's a really good question. So I think this may vary from center to center. For us, for example, putting a note in the chart is something that we do sort of electively, and it takes a fair amount of work actually. Everything that I'm telling you about is a fair amount of time and energy to put together and to document. And I would say, so we do have a note. It's not an official templated note. It doesn't necessarily get sent to referring providers. I would say it's typically more ordinarily used for internal purposes. It becomes part of my routine when I'm seeing patients. I can look back at our previous tumor board notes. But in our particular system, it's not something that routinely, for example, goes on my chart or routinely gets sent to your local doctor, other than it will typically get incorporated into the next note when I see a patient in clinic. I pull over our tumor board findings into my notes. Other places, it may be more formalized, where there's an actual part of the chart that's a tumor board part of it. Depends on the electronic medical record system that you're using. I don't know if you guys have how you do it in terms of your clinics, but do you have any other thoughts about that?
No, I think that's right. In general, the notes don't go to the patients, but the communication is through phone or my chart or other methods. Yeah, it's a good question though. There's no formal letter to the patient based on the conclusion of the.
How does the patient find out whether they've been in front of the tumor board?
Oh, well, so normally what happens is, I'll just tell you how we do it. We might see a patient in clinic, tell them that we're not sure what the next best step is. We're going to present your case at our tumor board. And then in our particular system, what we do is at the end of the case presentation, we decide who's going to follow up with the patient or the provider, depending on if there's a reason to do that. On the other hand, if the patient has an appointment the next week, then we'll just talk about it in clinic when they're coming in. So we do make an effort to try to close the loop, either with the referring provider or with the patient, if they don't have follow-up in the short term with us. But it's definitely individualized, because every patient's different, because there are many patients that are going to be seeing Tom next week or Nick the following week, and we're just doing a tumor board presentation in between my visit with the patient and when they're seeing Tom. So it's variable.
So, Dr. Bergslin, do you repeat to the patient what the different set of opinions are, or just what the consensus is of the tumor board? I think that's something we'd like to know of, are there multiple opinions going on, and how do those get resolved, and do we know about them?
Yeah, I would say that it's not that granular in terms of when we are following up with patients. Usually we're presenting the consensus of the tumor board. Oftentimes that consensus, to be honest with you, is you could do this or you could do that. But we document that the group was undecided about what's the next best thing. Sometimes the consensus is get another DOTA scan in 6 months, or get another MRI with EOVIST in 2 months, or the patient should have that spot that's growing be biopsied, and then we'll circle back and talk about it later. But it's really, the tumor board is really meant to be a way to, while it profoundly ultimately impacts patients, it's really to support the providers who are taking care of the patient, to try to make sure that the providers are basically able to come to a consensus about what's the next best step. And I do think, again, we do try to circle back ultimately to talk to patients, but it's variable when and how that happens depending on when the next follow-up appointment is.
I sort of have a question more about what you said about treatment than the tumor board per se. I was just wondering, you were saying that some people you go for stability and the other people you go for shrinkage of the tumor. Is there any particular reason why you wouldn't want shrinkage in everybody, other than, are those treatments just generally harder on the patient? Is that why you don't go that route for everybody?
Yeah, so it's a really good question. So the question is, why would you ever want to just settle for stability as opposed to look for shrinkage? And I think the bottom line is that there's a spectrum of the disease, of the treatments we give, and they tend to get a little more invasive. So for example, what Dr. Fiddleman does is liver treatment, which is an invasive therapy, and there are potential side effects. What Dr. Hope does is radiation by PRT, and while it can be very well tolerated, there can also be some side effects. Whereas lanreotide and octreotide, same thing, you can have side effects with those, but they tend to be relatively minor compared to some of the side effects you have with other treatments. So it really just, if you have pancreatic neuroendocrine tumor, what I always tell patients is you're probably going to have all of these treatments eventually. It's just a matter of in which order you're going to get them. And we usually start with the easiest, safest, most well-tolerated treatment, and then we move towards these more invasive things over time, depending on what the goal is and the need is.
I think another way to look at that is, that's why I like this last slide here. I think this slide's a great example of how you would think about that. Like, for example, this patient has 2 sites of disease, right? Very small, 2 little metastases, and in that setting, stability is just fine, right? You don't need to make those shrink or go away. And so thinking about treating a patient like that with a stabilizing therapy is very reasonable. You can buy as many years as you can with stability, whereas if you have someone with much more extensive disease or something like this, the extent of disease and location of disease really dictates how aggressive you want to be. And then obviously the more symptoms you have, then I think where liver targeted therapy really comes in is if you want to debulk or shrink quickly to control symptoms, then you can start to consider that. So that's where extent of disease, location of disease, the symptoms, all that comes together into deciding which type of therapy you'd like to do and which should come first versus second. Does that sort of help?
Yeah, I don't want to go into this too much, but even this guy with, or person with 2 sites.
Yeah.
When the cancer spread less quickly, if you got rid of those 2 tumors?
If you can get rid of them, I guess. But the thing is here, this patient with lanreotide could look like that in 3 years, right? With very little toxicity or morbidity associated with it.
It would not necessarily spread more quickly, and you're also as good as the test that you have, right? So there can be other places where it's hiding. It's just not big enough to actually show up in this test. So chasing a spot or 2 that happens to be hot on the scan actually may be in somebody's not in their best interest, because you'd be subjecting somebody to an invasive operation that may have its own side effects and recovery issues and so on, just to find out that 6 months later or a year later, okay, well now it's here too, and then what? Then you put somebody through this recovery, through this invasive procedure, but really you've accomplished not very much, because if you just gave them the stabilizing agent, it would have looked similar, or that plus a couple little spots that year later anyway. So it doesn't really change that whole outlook. But I think what these scans are also showing really nicely is the frequent conundrums of why we have to have the tumor board, because you can see how different the distribution can be, and we might consider localized liver therapy if it's all in the liver. So those 2 patients on the right side, this one and that one, they have liver spots all over, and really very little else. There may be a primary tumor where the red cross is actually on that picture. That's the primary tumor, probably in the small bowel. There, right there. But there's really nothing else, and so you wonder, okay, well, it's all in the liver. We can treat the liver, and so that's part of that also what goes in the discussion. But this is just a static picture. You don't know what it looked like a year ago. Maybe it looked very similar a year ago, at which point we would say, oh, well, this is fine. We'll just use a static agent. But maybe it looked a year ago, but now the symptoms are way worse. Maybe this person now has way more flushing than they did a year ago, but the picture looks fairly similar. So as Dr. Bergson showed in that chart, where there are these categories of things that go into that decision making. they do go into the decision making, because you can't just go by what the picture shows. Yeah.
Yeah.
Maybe just to piggyback on what you're asking, it seems like it would make sense to just wanna get rid of the tumor, right? But I think based on the fact that neuroendocrine tumors are a different genre in themselves, the methods of treatment are different, right? And that kind of like what people think about when they think of cancer and having a tumor and you just wanna get rid of it, it's a different approach to treating these sorts of tumors, because a lot of the time they have slow progression. Is that correct?
Yeah, it's a really good way of looking at it, and in fact, to put it even in like very basic form, like you could imagine for some patients it's a chronic disease. You know, where as we look at it as providers, that it's a disease that you might be expected to be living with for hopefully many, many, many years. And so it really is treated differently than some other cancers that are out there. But I will say that, like, getting to that point about that second panel in with the very, very low volume disease, I totally understand the question of why not just take it out. And we do ask that question, we have that conversation. But we have data now from the liver surgery literature that when you do liver surgery, the recurrence rate after liver surgery approaches 100% in 10 years. And that doesn't mean that we shouldn't do liver surgery, but it means you need to think about that when you're doing it. And I would say the same is true when you're resecting other sites of disease that are considered metastatic, that you often technically can do it, but the question is, should you do it? And what will you gain from the gain for the patient in doing that? Sometimes the answer is it's a good idea to do it because we think we can set the clock back. We can have the disease burden be what it might have been 5 years ago or 10 years ago, and the risks of the surgery are worth doing that. Other times we say, again, because of where the location is or the prior surgery a patient's had or their other medical problems that they have, that the risks of surgery are just not worth it, that it's too dangerous to do it. And again, remembering that somebody like in that second panel where it's just very low volume disease, that person actually might do perfectly well with no therapy for a number of years. And that person may not need anything, not even octreotide, for quite some time. So we have a lot of these conversations in tumor board when, say with that low volume patient, very little disease, just a few spots, but it's growing on the scans. And that's the most frustrating situation that actually honestly has become more of a problem now with our pretty high quality imaging. We're picking up smaller amounts of disease, but yet you can see it's grown 4 millimeters in the last 16 months. So, you know, we'll have that conversation and then we bring it back to the patient, and that's a hard conversation to have, but sometimes the right thing to do is actually to not change therapy. Because the risks of changing therapy and going to drugs like, you know, PRT or everolimus, etc., may not be worth it in the context of very low volume, slow progression. And I don't have an answer for you of what's the actual cutoff, when is it that you start therapy, but this is the kind of conversation we have internally and what we have with the patient. Because it's hard to have tumor that's slowly growing and not do anything about it, but we have to consider what are the pros and cons given the available treatments that we have.
I know having a dotatate or a net spot has been very beneficial to you being able to have these conversations. There's certainly a decent number of patients or percentage of the patients who don't image on dotatate. And so what type of tools are you using to discuss them in tumor boards? I think a lot of patients are concerned when they know they have disease but they're not showing up on a net spot.
We use other forms of anatomic imaging. We use CT scans, we use MRIs. We pretty much use anything else that would be available and would be reasonable to obtain, and that's how we make the decisions.
I think I'd break that into 2 categories, right? One is a patient who has metastatic disease that's dotatate negative, right? That's one group. In those patients, you might get FDG PETs, anatomic imaging, et cetera. I mean, even if you look at this first patient here, look at the intensity of the liver. This patient's disease is probably less than half as average as the liver, which, although it's technically positive on dotatators, has very low uptake. So that would be a type of patient you probably wouldn't follow that patient with dotatate PET. So that's one category of patient, and I think you would rely, as Nick said, on anatomy. But there's another group of patients, which I think is what you're referring to. It's more patients who have no evidence of disease on any imaging, and a dotate's negative, and may have symptoms, flushing, diarrhea, or something like that. And I think that is a different category. It's very hard to deal with because, in essence, no imaging shows us their sites of disease. And if you don't know where their site of disease is, it's very hard to do any type of therapy, right? So PRT is not an option, liver-directed therapy is not an option. You're not going to do systemic therapy if you can't measure your disease. So in that category, I think it's very difficult to actually work with the patient when you can't actually localize where the disease is. I don't know if that's what you're referring to.
Both are kind of what I was getting at. They may have some biomarkers that
Yeah.
would kind of, you would be suspect that they have disease, but you may not have been able to image it yet. And actually, you're right on there with you can image with conventional imaging as well, and track disease and have other treatment vectors to go after that aren't related to receptor positive disease.
Other questions?
Do you think that there'll ever be a time where they can actually image consecutively the same spot the same way? Because every time you go for imaging, they'll say, oh, it was a little off, or a different machine, or more contrast, less contrast, but different, imager. Do you think down the road that there will be such an animal as that machine that could constantly make it comparative?
I think it sort of already exists.
Okay.
Which is, it depends on where your disease is. If you have liver-dominant disease, EVIST, hepatobiliary phase, MRI is actually incredibly consistent. So Dr. Bergslund showed a slide of the 3 different phases of the liver and how the contrast changes. We call that sort of dynamic enhancement, right? So as that the bolus of contrast comes through your liver the first time before it gets diluted in your blood, you see different enhancement patterns. And that can be very dependent on the timing, right? Because if you're 10 seconds early or later, the way that the dynamic enhancement is very impacted by timing. But hepatobiliary phase, or the imaging we use with gadoxetate or EVIST, that is a static image about 15 to 20 minutes after injection. So there, you can image liver lesions reproducibly over and over again using that modality. So I think, and that's sort of a point we try to get across in many different avenues. But for liver-dominant patients, which is where this issue comes into play, EVIST or hepatobiliary phase MRI is actually very reproducible and can be used to track slow growth in patients over time. The other thing is for lymph nodes, CT does work very well on the other hand. So if you have nodal disease, then a CT is actually the best way to follow that disease. So that sort of depends on where your disease is, which is why Dr. Bergslund was highlighting at the end of our tumor board. So we oftentimes ask, well, what should we follow this patient with next over time? And then the thing I think is hardest is that patients will oftentimes come in with a CT done a year ago, an MR done, 6 months ago, and a dotatate without contrast done a week ago, and you're out of luck. It's nearly impossible to compare 3 different modalities like that over time, and I think that's where it becomes very difficult to determine whether or not patients are growing or not, because physicians will sort of go between modalities intermittently over time, and I think that's what causes the biggest problem. Not the actual technology itself, but the way it's used and the frequency of the use. I think that's what becomes really hard. That's my take.
Or where they measure, how they measure, it seems like it's variable.
Yeah, so I mean, a measurement of a lesion can obviously be impacted by the ME or the NIC. We put calipers, we measure lesions, and there's a little bit of variability in that. I think the key is, you'll get a report. I'm sure you read your reports, and it'll say lesion measures X by Y, right? Mm-hmm. And you look back to yours and you say, okay, I think that's the same lesion. They measured X by Y. You need to have the person measuring them at the same time, if that makes sense. So it's very hard. If you gave me two studies in a patient that are 2 years apart, and I measured one study and I went away and came back a week later and measured study 2 and then compared the results, it's very different than me looking at the two studies next to each other and measuring them at the same time. Does that make sense?
Yes.
So, like, there's definitely variability in measurement, but that's why you have to measure it comparatively at the same time so that you're using the same approach to measuring. I don't know if that's helpful.
I mean, maybe people don't know this, but maybe we should just talk about how you actually measure tumors. It's not automated. So do you guys want to just
Yeah.
say?
No, right, it's not automated. We
It's
find
but
the,
manual.
yeah, find the picture where it looks the largest, and oftentimes just measure the longest diameter, or do a cross section of two diameters where it looks the largest, because sometimes over time the tumor can grow out of proportion to itself. It might start looking more round, whereas it was more oval. And so if the single measurement may be deceiving. It may look like the lesion has changed a millimeter or two, but if you add the second dimension, you find out that it's actually not. For some clinical trials, what's called RECIST measurement criteria is used, which relies on a single measurement. So that can be misleading, right? If the tumor goes from oval to round, it may have doubled in volume, but the actual single largest diameter of it has not changed at all. So you know, there's other criteria that are now used for for trials that, you know, that go beyond RECIST and go and become a little bit more. But that's just talking about trials. I'm just talking about now just talking about the routine measurement of lesions is we just find where it looks the largest, the most representative, and that's where the measurement is taken.
I think you can sort of, if you look at like a patient like this, and you have 100 lesions, you can't measure 100 lesions, right? So you look at the study, compare it to the prior, you get a gestalt, I think it's growing or not growing, and then you take some representative lesions, you measure these 3 at both time points, and you see if it fits your gestalt, and then if it does, you report the size of those 3 lesions. Does that make sense? Like there's a little bit of an art form to it in terms of getting it right. And I think the most important thing is this over time aspect, and I think that's the hardest thing for most radiologists with NET. Is we're used to looking back one study and saying, oh, there's no change, or it's grown, or it's responded. But neuroendocrine tumor patients have very long horizons of growths of their tumor, and you have to look back 2-3 years sometimes, maybe even longer, to really actually ascertain if the patient's growing or not, which can make it even harder.
And just to follow up quickly on that, I saw somebody recently where the radiology report comes back, they have the measurements, they usually give you 3 or 4 index lesions where they give you measurements, and it looked like it was growing, so I ordered a DOTA. And then at the last minute I said, I'm going to ask them to do an addendum and look back 3 years, just so I am sure that this is growth. And lo and behold, it's totally stable over a 3-year period. So, you know, I'm just saying, subtle progression you have to be careful about, because it may not be real, and it may not be in the patient's best interest to be changing therapy until you're really sure that it's growing. And these subtleties, what lesion did the radiologist pick? What phase of contrast are they looking at when they're measuring versus what the person 6 months ago was measuring? That's really, really important. And so it can be really hard to tell just from the report, I guess, is the take home, which is why I find it high value to look at the scans together in our conference. And so, yeah, so there and then there.
There must be a incredibly high margin of error measuring tumors also, because my tumor was measured at 2 centimeters, and then when I took it out, it turned out it was 4 centimeters. So it was twice as big as I thought it was.
There's the element of what you see is as good as your imaging study. So, you know, the imaging study can be, you know, can show what it shows, but then, you know, the pathologist sees it.
And also, though, it's a 3-dimensional thing, right? So what was measured when they measured 2 centimeters, right? It might have been 2 centimeters across, but 4 centimeters down, you know, lengthwise. And so I think you raise a really good point. It just depends on what was being measured. The other possibility, you know, some tumors grow, but again, in this particular case, we're talking about slow-growing tumors where a lot of variability is fine.
Do you have recommendations on how often a patients should have a DOTA scan depending on their disease burden, particularly NED patients?
Has one weigh in on that?
A DOTA scan in an NED patient, that's a hard one. So I think in general we recommend against somatostatin receptor PET as a routine screening study in a patient who has no evidence of disease. That doesn't mean you shouldn't get another one at some point in time, but it's, you know, I think this is a great example of patient of what's the point of catching centimeter lesions that you can only see on DOTA, which you can't see on anatomic imaging. And I think it's unclear what we would do with that anyway. So you have to think about the role of imaging in the setting of what are you going to do with the information. And so at some point in time, particularly patients with very low volume disease, you're probably not going to do anything with that information in the short term. And so there is a sort of general overutilization of somatostatin receptor PET because it is clearly the best way to visualize the disease, but you don't always need to know the accurate extent of the disease at every time point, and you also don't always need to know the somatostatin receptor status, right? So if you're deciding if you want to do PRRT, or if you suspect progression but it's not clear that it's happening on conventional imaging, in those settings, somatostatin receptor PET is very important. But in other settings, I think it's of limited value clinically, if that makes sense. And again,
Yeah.
it has to be sort of discussed, so we also discussed that sometimes.
It relates to the issue of the frequency, the rate
Mhm.
of metastases from primary. We know in some diseases that metastases occur very early in the progression of the disease, before they're a millimeter in size. Gone. It's a systemic disease. What do we know about neuroendocrine tumors of different origins, pancreas versus gut versus lung? There's the rate of metastases and how early they metastasize.
Well, I would say you're on the edge of the envelope in terms of what we know, but in general, I can say for pancreas tumors, as a very rough rule, metastases seems to relate to the size of the tumor. But on the other hand, in small bowel tumors, you can have metastases to lymph nodes with really, really small bowel tumors. So there might be a little bit of a difference in the biology there. And I would say the other kind of end of the spectrum with the high-grade neuroendocrine carcinomas, there's a very high rate of metastases even in very small tumors. That's a different biology entirely in terms of the what's driving the cell growth and the molecular features of those tumors, just a very different biology entirely. But to follow up on Tom's, I would say the standard of care in the field right now is that DOTA scans are used at diagnosis to stage patients. For most patients, unless you have just a very, very, very tiny tumor, it's usually done as part of staging. And then it's done at the time of evidence of recurrent disease, but it's not done as routine follow-up after surgery, for example. It's done if there's an abnormality found on a scan in the context of follow-up, then that would trigger a DOTA. And then the third time that we do DOTAs are in somebody who's known to have advanced disease, who's on a therapy, but now there's progression. We'll do a DOTA at that point to look and see where the progression is the tumor DOTA avid, et cetera. But so, and I would say we are reasonably good about following the published guidelines on this, and so those would be the basic time points that you would do DOTA scans, and the other scanning that's done during the course of somebody's disease continuum, it's CT scan or MRI typically. The one caveat is we do sometimes see patients whose disease is only in the bones, and that's a really tough situation because CT and MRI are not great for monitoring that, and so in those situations sometimes we'll have to do more DOTAs because that's the only way to effectively monitor the disease.
I think Dr. Hope was the lead author of a paper for, how many were there? 7, 9? I always forget. The appropriate use criteria.
I think there's 9 indications. Is that what you're talking about?
Yeah.
Yeah.
So
I
we
could
have
be
it
wrong.
available on our site. I'll remind people of it, but there's a paper that was put out by SNMMI and a few others on the appropriate use criteria for gallium-68 or somatostatin positive imaging.
It's a great article.
I know, I'm a co-author too.
Is there a difference
Yeah.
in how you treat or level of concern in patients who have a lot of really small tumors as opposed to fewer very large tumors?
Very much.
Yeah, it's a really good question. I'll let Nick, why don't you
Yeah,
tackle that
very
one?
much. I mean, sometimes a few very large tumors could be taken out surgically, and so you think about surgery a lot more about then. You definitely size and distribution counts. That's how I would probably leave it in terms of general terms, because, are we talking about thousands? Are we talking about dozens? Are we talking about, 5 or 6, and their size? But I think the one thing that really matters, especially in the liver, is if there's few larger ones, surgery really comes to the forefront versus, dozens of tiny ones where, from the practical standpoint, trying to shell out every single one of them becomes not possible. So yes, it definitely plays a role.
Tom, do you want to talk about how that might impact PRT? Large, bulky tumors versus small?
Yeah, so I would say with PRT, it's unclear exactly how large and small interplay with the efficacy of PRT. There is impacts in terms of if you get too small, and we're talking millimeter, a couple millimeters smaller, then you don't get enough crosstalk of the radiation within the tumor, so it loses efficacy. But the larger tumors, theoretically, if we'd use different types of radionuclides like yttrium-90, but it's not really widely available in the U.S. I think the distribution is really important for PRT decisions based on, when does a patient sort of stop becoming a surgical and then to interventional, liver-directed therapy to PRT. Sort of goes from a few large is definitely surgery, lots and lots and lots of little small ones or full replacement of liver is going to be on the PRT range, and then liver-directed therapy comes in between there. And this is the type of discussion we have all the time in tumor board is, well, is patient 3 or 4? 4 is probably most likely definitely more of a PRT patient. 5 is PRT. 3 is maybe one where liver-directed therapy becomes a question, and then maybe should we do liver-directed therapy first, debulk the big ones, and then do PRT afterwards. But I wouldn't say there's a one-to-one size impacting PRT, but it really impacts when you do A versus B. And I think we just don't know the answer to many of these questions, and so that's why we get a lot of debates over what we should do in various patients depending on the site, extent, and size of their disease.
And is it also impacted by where the tumor is, large or small in the bones versus large or small in the liver or the
Yes,
pancreas?
absolutely, that makes a big difference. So obviously liver-directed therapy is only in the liver.
Right.
When you get out of the liver, if you're in the mesentery or pancreas, then you can start thinking about surgery versus systemic therapies. If you're in the bones, then it's other systemic therapies versus PRT. So I think what are the other therapies you're thinking about is obviously impacted dramatically by the extent of disease, location of disease, and then even something you also don't oftentimes think about, but which part of the disease is growing, right? If the liver is stable and the stuff in the bones is growing, then that changes your approach. If it's only the liver disease growing and everything in the bones has been stable for 5 years, well, actually, even though you have extra-packed disease, liver-directed therapy might be a good approach. So, it gets to be very complicated, and that's why having the imaging with the surgeon, with the interventional radiologist, and Dr. Bergsland looking at it all together, trying to ascertain, well, okay, let's think about if this is true, go back to the imaging, compare to the priors, okay, well, it's not like that. What about this therapy? Thinking about each of the therapies in the setting of all of the specificities of each patient actually is sort of complicated. It gets to be hard.
Thanks.
Last couple things, I wanted to mention one other group of providers that's really helpful, and that's radiation therapy. They aren't here today, but radiation therapy can be really valuable for focal radiation to certain spots. So I'm not talking about the IV radiation that Tom does with PRT, but I'm talking about radiation to a painful spot in the bone. Or sometimes we'll do it if there's a little growing lymph node or one growing spot in the liver, there's certain types of radiation you can do to those particular spots. And I've found that often tends to be helpful for the low volume disease that's growing, but you don't want to subject the patient to, you know, pills or other chemotherapy, things like that. So that's another group of providers we haven't mentioned. And then along those lines, I wanted to mention in terms of Nick, what he does in liver therapy, that you can have too much liver disease for liver-directed therapy, but you can also have too little liver disease for liver-directed therapy. And that's another thing that's, you know, just another caveat. I don't know, Nick, if you want to expand on that.
It is ultimately a balance of risk and benefit, right? So liver. So when we treat with any of these agents, we consider, okay, the healthy body reserve has to be maintained, and that is of paramount importance, because if we deplete that reserve, then that pretty much usually means the end of the road for a particular kind of therapy, or maybe even sometimes for multiple therapies. And liver is such an important organ in that it metabolizes all these drugs and toxins that we need to maintain its health. And so whenever we consider, you know, any treatment really, in particular liver-directed treatment, what we want to maintain is that balance of health. By treating too soon, we're exposing too much healthy liver to whatever it is that we inject in there. And the minority of the stuff that we inject actually goes where it needs to, where it really counts. When you treat too late, then the amount of healthy reserve is too low, and then a person reaches a tipping point, and you might actually throw them over the edge by destroying just a few % of that healthy tissue. That may be enough to completely topple the whole pyramid, because it's just barely teetering on edge, and you know, just a little bit of that healthy tissue becomes really critical. And there seems to be kind of a sweet spot, I don't know, anywhere from about 10% to about 70 to 80% replacement of liver by tumor. And that said, that number is very hard to come at, because if you have 1,000 things in there, how do you really figure out that percentage? It just becomes this very sort of a gestalt thing. You're looking at the blood tests to see if there is any synthetic abnormalities of liver function, and various other signs on a physical exam or on a scan that might suggest, okay, the liver is not working too good. We have to be really gentle. The liver is working really robustly. We can be a little bit more liberal about what we do. So much of it is just sort of, you know, how it appears, how the whole picture fits together. And it's not just number, it's not just size, it's not just total percentage, but it's also what happens over time, what else is going on.
And what other therapies you might do in the future, like with the bone-directed radiation? Would you not do that if you think you might use PRRT later for the?
Right, that's exactly right. So it
Right.
really depends. If it's somebody has one bone spot that hurts, then it would make sense to just do regular radiation to that. Whereas if it's like the last person depicted on this slide, where there's a lot of bone disease, then it might make sense to do PRT. So these are all really great questions, and hopefully in this hour we've at least given you some idea of what we think about when we're doing this. And this same sort of process happens at a lot of institutions. It's very, very common to do this. And it may be behind the scenes, though. You may not be seeing about it or hearing it, because it's often just done informally in a room without a written report necessarily. But I think this is a very important part of the process for patients with neuroendocrine tumors. So hopefully this has shed a little light on that. Yeah.
Could you touch on the role of the genetic counselor?
Yeah, that's a really good question, and then we should probably finish up, because I want to make sure you guys have your networking session. But
thank you.
I would say genetic counseling isn't something we've always had. It's something that we're lucky enough to have here. There's somebody who's been coming regularly, and it's become a little more important for neuroendocrine tumors, especially for pancreas tumors, where we now know that maybe roughly 15% of tumors may have a genetic component. But so our genetic counselor will come and listen to the case presentations, and sometimes we'll have insights on either the prior testing that a patient had done. Was the testing that was done 5 years ago adequate, or has the technology changed that we should consider retesting? Or they might notice patterns in the patient's history or family history that suggest that we should consider retesting in a patient that we had not yet tested. But genetic testing is not ubiquitous. It's not done on every patient. It's done somewhat selectively depending on the patient's family history, their personal history, and also the type of tumor that they have. Okay. All right. Well, thanks so much, everybody.
Good job.